This is a case of pulmonary artery atresia with non-opacification of its distal branches as a consequence of pulmonary thromboembolism. Generally, pulmonary artery atresia is associated with congenital conditions such as truncus arteriosus or tetralogy of Fallot. However, our patient was unusual in that she had no congenital conditions and yet had atresia of her right pulmonary artery with resultant right lung volume loss. So this case is a case of an 85-year-old woman with a recent history of bilateral deep vein thrombosis who was treated with warfarin outpatient and presented to the emergency department with dyspnea and chest pain. She was recently diagnosed with her DVTs and was admitted to the hospital and started on warfarin. She was supposed to follow up with her PCP outpatient after 7 days, was unable to, and therefore has not been taking her warfarin for 3 days prior to admission. In the emergency department, venous Dopplers of the lower extremities showed chronic appearing non-occlusive thrombus of the right common femoral vein and proximal right superficial femoral vein, and there was no left-sided DVT. CT angiogram of the chest did not show any acute PE. However, it did show abrupt tapering of the right main pulmonary artery, and there was no visualization of its distal branches. Additionally, the volume of the right lung was diminished or decreased, and there was pleural thickening and apical scarring of the right lung. In this imaging area, in figure 1A, CTA of the chest shows that the left pulmonary artery continues downwards in its normal course. However, the right pulmonary artery abruptly tapers and does not continue, and you can see that there's no distal vessels as well on the right lung field. In figure 1B, this is a CTA of the chest as well and is a coronal view, and here too you can see the left pulmonary artery descending into the lung, and the right pulmonary artery is abruptly tapering as well here. As similarly, there is no right pulmonary vessels that you can see in this image. And figure 1C, this is a lung window of the CTA chest, and this is showing the right lung field or the right lung volume is diminished in size, as well as there being chronic scarring and pleural thickening in this image. So upon further evaluation, the patient stated that she had an old pulmonary embolism diagnosed in the 1970s. She was pregnant and was therefore not treated with any invasive measures. She was also not anticoagulated. However, she was given a course of antibiotics. On this admission, she was treated with apixaban 10 milligrams BID for 7 days, and that was then followed by 5 milligrams BID indefinitely, as this was a recurrent DVT or thromboembolism, and she was recommended to follow up and made an appointment for hematology outpatient. So this case is unique in that it highlights a presentation of atresia of the right main pulmonary artery, where it abruptly tapers soon after it bifurcates, and this is in the setting of an old pulmonary embolism. It's unrelated to any congenital abnormalities, which is when we usually find pulmonary artery atresia, and there is no other literature that talks about a case such as this. Additionally, this case is important as it demonstrates that how important it is to use evidence-based management, and it should be done in a timely manner to treat pulmonary embolisms. Otherwise, there can be long-term ramifications, as in this case where she had an infarct of the right lung resulting in right lung volume loss. So this is in summary, it's a report an unusual patient with pulmonary artery atresia with non-opacification of its distal branches and right lung volume loss from an old pulmonary thromboembolism, and it is unrelated to any congenital abnormalities.